It is my privilege to introduce Dr. Gautam Khastgir. He is recipient of Wellbeing Research Grant in the UK, reproductive medicine subspecialty training at the Royal College of Obstetricians and Gynecologists. He has an RCOG accreditation in endoscopic surgery. He has published research papers in infertility, hormonal therapy, endoscopic surgery, published in international journals. He has provided hands-on training to over 250 doctors in infertility and gynec endoscopic surgery. Certain milestones are that he has been the organizing secretary of ESAR 2018 conference at Kolkata. He's the chairperson of ESAR Bengal State Chapter 2020 to 2022. He's then elected member, ESAR Executive Committee 2020 to 22. Organizing chairperson, ACE 2021 conference at Kolkata. Organizing chairperson, Yuva ESAR 2021 at Kolkata. Currently, he's fighting an election for librarian ESAR. So welcome, sir, and all the best. And we are waiting for your lecture. Welcome, Dr. Gautam Khastgir.
Thank you very much. Thank you very much, Dr. Asha, for that kind introduction. And before my lecture, I would, with your permission, with the respected chairperson's permission, I would just like to say a few words, which I say gratitude time. Basically, to start with, my heartfelt thanks to Dr. Lakshmi Shirikhande, a very good friend for last 20 years. And it is with her initiative, today's program, I'm here. And I know her for her enthusiasm for education, for clinical work and organization. And after seeing her and my other good friend, Dr. Jaideep Tank, who has been so supportive when I came back from UK to let me enter into the system, to understand the system in India. And I'm ever so grateful. And I'm sure he's going to win. And we will see him as a president. So being as a chief guest, many a time, some people ask me, why don't you do menopause? Because you have worked with Professor John Studd, one of the pioneers of menopause. So I say, yes, I do work with menopause patients because many of my patients are having ovum donation treatment. So it was very appropriate when Dr. Shirikhande asked me to talk in this program. I said, I'm going to share my experiences of estrogen, which is a hormone often not given that importance in infertility patients. We are just talking about progesterone, luteal phase support. My gratitude to Dr. Ambuja Madam, the respected president, and Dr. Sudha Sharma Madam, because you're doing a wonderful work in IMS. And I have been a member of IMS for a long time. Dr. Ratnabali Chakravarti in our state has made IMS in Kolkata really vibrant, and I was very active in the IMS conference in Kolkata. Now, finally, I'm ever so pleased to have Dr. Professor Jayam Kannan, whom I've considered as a walking encyclopedia, to be very honest, because you ask her anything and she has a solution, and she's so humble. You go and ask her anything, she will answer. And if you're in the incorrect path, she won't say that you're doing wrong. She will politely say, I would have done it in this way. So I'm really enriched. I'm really enriched. Truly, I'm really enriched. And I thank all of you, whether I become a librarian or not, but this journey has really helped me. My whole intention has always been to bring education to the forefront, to train our colleagues and juniors, and let's all work together. And I say this in every meeting. We Bengalis are very fond of Rabindranath Tagore, and he said his songs have to be sung in a particular way. So he has made the tune, not like modern songs, which you can sing in any way. So if you all sing in a particular way for menopausal problem, particular way for infertility and endoscopic surgery and pregnancy, then we will be the best country in the world in terms of giving service, because our population is our power. So the amount of work we do, sometimes we do not publish because of lack of time. So whatever strength we have with the population, we should utilize. Now let me share the slides. I must say this my wife would have said, once you start talking, you do not stop, let others talk as well. So let me just share my, right. Can you see my slides?
Yes, yes.
Okay, thank you. But today I'm going to talk about ERT and ART. Interesting, isn't it? ERT and ART. Now, I've already mentioned why I would like to prefer on estrogen, because my teacher, John Stark, told me estrogen is actually the hero and progesterone is the villain. Why did he say that? He said all the good things in the brain, in the heart, in the uterus, everything is done by estrogen. And progesterone is, of course, necessary for protecting the uterus, but it is responsible for most of the symptoms, side effects, like bloating, breast tenderness, irritability, PMS, everything is with progesterone. But he was referring to synthetic progesterone, and now we have both natural estrogen and progesterone. So they are very good friends. They are like twins. We need both estrogen and progesterone. Now, estrogen replacement therapy is, of course, essential. I was brought up by saying that every woman should have estrogen replacement therapy. But now with the Millennium Women's Study and Women's Health Initiative, that idea has changed. And you know everything about it, that we should not give estrogen to everyone. We should only give it to the symptomatic patients. But when we are doing infertility, when we are treating our patients with ART, we need estrogen in 3 different aspects. One is for the frozen embryo transfer, particularly those women who have irregular and anovulatory menstruation. In a regular menstrual cycle, you may do FET in a natural cycle, or you may give them ovulation induction with gonadotropin or letrozole, develop good endometrium and transfer it. But those who have irregular cycle, where you need to suppress the hypothalamic-pituitary ovarian axis with GnRH agonist, and then use estrogen and progesterone to develop good endometrium. In those women, we have been talking about, just our respected Secretary General, Madam, said, making mothers out of grandmother. Unfortunately, we can only do it up to the age of 50. I've treated many women between the age of 50 and 55. After lots of consultation and counseling, particularly after the death of their grown-up children, they were absolutely shocked and shattered, and many of them wanted to commit suicide. So one of my patients was at the age of 59, and she lost her daughter, 23-year-old daughter. Now, we ask ourselves, are we playing God? But the issue is, you develop an ethics committee, you ask non-medical person whether it is right or wrong, you talk with the family. If there is family support, we were really hesitant because she was 59 and husband was 65. So when this baby will be reaching adulthood, maybe both of them will be gone. So is it right? The child may come to me and say, who are you to bring to this world? But on the other hand, the desire is so much, but now we cannot do it with the new ART law. We can only treat women up to the age of 50. So these women would require ovum donation and embryo donation. We cannot say embryo donation now. So ovum donation and embryo and sperm donation. Now, the other big problem we have is the management of thin endometrium, which is very common in this part of the world because of genital tuberculosis. Now, it is true there has been a dramatic increase in the incidence of FET cycles because the results of our embryo freezing by vitrification is very good. We would like to eliminate the risk of OHSS. So we are using more GnRH agonist trigger and freezing all the embryos. Now, many a time what we see, there is better synchronization of endometrium and embryo if we do mild stimulation. But when you do hyperstimulation, there is advanced maturation of the endometrium. So the implantation is not so good. In these cases, what we do, we actually freeze the embryos and transfer them in a subsequent cycle. When we are practicing elective single embryo transfer, which I do because I've seen so many adverse effects of multiple pregnancy, particularly in high-risk women, particularly in elderly women, I've stopped transferring more than one embryo unless it's a repeated implantation failure or a very difficult case with a low prognosis. Those who are doing pre-implantation genetic diagnosis and screening, they need to actually freeze the embryos, wait for the result, and then transfer in the subsequent cycle. And finally, elevated progesterone in the late follicular phase, we all know suggests that the endometrium may not be very good for implantation. And in those cases, we also do FET. Now, when we are talking about estrogen replacement, we have two common routes. One is oral and other one is transdermal. Now, if we look at the E1-E2 ratio, that is estradiol ratio, then we are not always aware the oral route gives an abnormal ratio between 3 to 6. And it also gives a much higher non-physiological level, much higher non-physiological precursor or metabolite. Whereas the transdermal route will give us a steady level of estrogen with the most physiological E1-E2 ratio, which is between 1 and 2. Now, it has been published that endometrium will react differently to the altered ratio of estrogen and to the different level of circulating estradiol level. So we need to keep two things in mind. What should be the ideal level of estradiol in the circulation and what should be the ideal E1-E2 ratio. Now, the other thing we often ignore or forget, although we know it very well, there are some biological effect of estrogen to the other system. Oral estrogen will go to the liver and it will affect the hepatic proteins like renin substrate, sex hormone binding globulin, thyroid binding globulin, and cortisol binding globulin. By this hepatic effect, it will also alter the clotting factors and lipid profile. And thereby the adverse effects are hypertension, intravascular clotting, venous thromboembolism, and cholelithiasis. Interestingly, transdermal estrogen can avoid all such problems because it is avoiding fast pass effect on the liver. So it is getting absorbed directly into the circulation and it is getting absorbed in estradiol form, which is the most important thing. Because the oral route is extensively metabolized in the liver and intestine, its efficacy is diminished by 30%. So we need to give more oral estrogen to get appropriate effect on the endometrium. And that is not the case with transdermal. And I've already said E1-E2 ratio is about 3 to 6 times higher. And estrone, we know very well, which is very high with oral estrogen, has a weak and lower binding affinity to both estrogen receptors, both a receptor alpha and beta. If you look at this chart, then the most ineffective is estriol, which we use transvaginally for local symptom relief that is not effective in developing endometrium. So we should ideally use estradiol more rather than estrone because it has got less receptor binding capacity. Now, transdermal route of estrogen will deliver the exact amount. It is consistent, the levels are consistent. But what we have to remember, when you look at the endometrial thickness and the efficacy, both oral and transdermals work. But in some cases, which is a minority cases, with oral estrogen, you may not get good appropriate endometrium. And then you can add on transdermal, and that will prevent breakthrough bleeding. Now, excuse me, the other thing is the safety. Now, transdermal estrogen being expensive, many a time we cannot use it, but in those women who have other problems like liver disease, clotting problem, diabetes mellitus, hypertension, for them transdermal is more appropriate. And the question is how long you're going to use it. If you are basically using it just for 1 or 2 cycles, it really doesn't matter whether you use oral or transdermal. But in those patients who will be using it for a longer period, like someone with primary ovarian failure or premature ovarian failure, they'll be using estrogen for a long period. Maybe they will start it at the age of 30 and they will continue until the age of 50 because they just don't need it for ART. They need it for their general health, for their bone protection, for their psychological upliftment, for their regular menstruation. They need estrogen. So in those cases, transdermal will be much more appropriate. Now, this I wouldn't repeat because I've already mentioned the ratio is actually different with different route. If you look at the serum levels, on the top I have estradiol, and the bottom I have got estrone. In black, it is the normal physiological level. In the middle, the spotted one is actually the levels we have in the form of transdermal. And on the right hand side, in the striped form, are the levels with the oral. So if you compare the top one, estrone one, you will see the oral estradiol level is much lower than the physiological. Transdermal is reaching almost midway or reaching the physiological level. On the bottom, if you come down, which is the estrone, again, transdermal and physiological are same, whereas oral levels are much higher. And this high level is also not desirable. If you look at the level over the period of next 24 hours after taking the medicine, obviously with the oral, there is a peak rise and there is fall. Whereas with transdermal, the levels are consistent. But what is more important in this slide is if you look at the serum concentration, that is the Y arm, the XY axis, with the oral, you see the levels are in the range of 300, 400, 500. So the levels are very high. Whereas with the transdermal, the levels are less than 100. So we are achieving a consistent level at a much lower level, and we are getting equal efficacy on the endometrium. Now let's look at some of the evidence. This paper suggested that transdermal is much superior to oral when we are developing endometrial receptivity. Another paper suggested that no single regime is particularly better. As long as you can give 10 to 14 days of estrogen, be it oral, be it transdermal. In UK, we are using estrogen implant, which is not available here. Patches, we were using it, which is not popular in India because of sweating. But they say transdermal is superior to oral route for endometrial proliferation, particularly in those women who do not respond well to oral therapy. Now, there's little confusion about the estrogen gel. Sometimes patients think we are, or even some doctors think that we are using a large amount. We are prescribing it in grams. But what you have to understand, the gel is in gram, and amount of estradiol within that is actually in microgram. So if you give them 2.5 gram, either by scale or by 2 squeeze, you are only giving 1.5 milligram of estradiol. So the standard dose for ART is about 5 gram daily, 5 gram of gel daily, which contains only 3 milligram. So when you are giving orally, we usually use 3 tablets of estradiol valerate or hemihydrate. So orally, we are using 6 milligram, whereas transdermally, we are giving only 3 milligram. And I'll show you the evidence that even with the lower dose of estradiol, the response is actually much better with the transdermal route because it's much more effective. And the oral is actually destroyed in the liver and intestine. And this is a standard practice which majority of you are doing it. You are down-regulating with GnRH analog in those people who have the normal ovarian function. Start estradiol on day 2 or day 3. And as soon as you reach 7 millimeter or more, you start progesterone. And finally, you do embryo transfer. Now, endometrial response in IVF, they compared 3 groups of patients. One is the natural cycle, one is a down-regulated cycle, and one is a menopausal patients. Interestingly, what was found that the menopause, the natural cycle endometrium is very similar to menopausal patients. So menopausal patients having ERT will simulate the natural cycle more. Whereas in down-regulated cycle, they are not exactly similar to. So all these informations are important. So when a patient has lost her ovarian function, she should not think that everything is against. Some of the things are actually in her favor. Now, the next big issue is the thin endometrium. It's an ongoing challenge. And we all face this and pull our hair to see what we can do for this patient. We have done hysteroscopy, we have removed adhesions. Empirically, some of us have treated them for tuberculosis, but still it is not responding. Now, why thin endometrium is a problem? Because with these, what happens is spiral arterial contraction with the help of estrogen will actually reduce the estrogen tension in the functional endometrium layer. So when the endometrium is thin, the spiral arterial contraction is not so well. So there is increased oxygen tension, which we know reactive oxygen species can cause a problem and avoid implantation. If the endometrium improves in thickness from 6.7 to 8.5 millimeter in this study, the pregnancy rate jumped from 4% to nearly 40%. And what was shown that you have to use a very high dose of 16 millimeter daily from day 3 and not only 4 milligram from the day of HCG. So you need to use a high dose for a longer period. The question is it okay for the patient? Patients feel very sick with such a high dose orally. Now let's look at this data published in Human Reproduction, where they looked at frozen thaw embryo transfer success and they compared with endometrial thickness. We all know 7 millimeter is the ideal. Only 1 millimeter decline from the ideal will reduce the live birth and clinical pregnancy rate. So lower the endometrium, lesser the pregnancy rate. But interestingly, there was no difference in the pregnancy lot rates. So it's like on an all or none law. Once the pregnancy takes place, even if it's a thinner endometrium, the pregnancy actually continues. Now, other issue we have is the higher estrogen level actually lowers the pregnancy rate. 3 very interesting papers suggested that uterine gene expression for embryo implantation is best at a proper estradiol level, and it will become refractory if the estradiol level is very high. And also the window of implantation will remain open for a prolonged period when the estradiol level is lower, but it will rapidly close at a higher circulatory level. And next is the duration of estrogen. Now, sometimes we need to give it for a longer period till the endometrium is ready. And because we have downregulated the cycle, or because they do not have their own cycle, you can actually use estrogen. And this study surprisingly used it for some patients less than 21 days, which is obvious, 10, 12, 14 days. But in some patients, they had to use it from 22 to 28, 29 to 35, and even for 48 days. Of course, the numbers were very low. And what you see, the live birth rate is actually much lower, and early pregnancy loss is much higher. So higher the dose of estrogen, longer the duration of estrogen, you're not going to get your optimum results. So be aware of that. Now for APT, we have meta-analysis and randomized control trial, and they said there is no difference according to the type of estrogen. Let's be fair. Let's not just assume that transdermal is best and oral has to be put in the back cupboard. Nothing like that. We can still use both of them. Endometrial thickness and clinical outcome were similar, but it was shown that the miscarriage rate was lower with a tendency of higher live birth rate. So pregnancy rate same, miscarriage rate lower, so higher live birth rate. Now, my personal opinion is when you look at the studies, suppose they are analyzing, I'm just saying for saying, said 100 studies, then 90 they have used tablets and only 10 they have used gel, because gel hasn't been used that much throughout the world because it came later. So when you have more people using gel, perhaps this randomized control study and meta-analysis will favor more towards transdermal route. Now, another study published showed that estradiol level in the oral group was significantly higher, which I've already told you. Drugs consumption is significantly lower in the transdermal route. Cycle cancellation rates were lower. However, endometrial thickness, both groups reached optimum 1. Biochemical pregnancy, clinical pregnancy rates in this study was higher. Miscarriage rate was lower, but it wasn't statistically significant. Now, another interesting thing, this paper published from the armed forces hospitals in India, that you have a patient who has ovarian failure. She's not having periods. She has come to you. Are you going to treat them straight away? Or are you going to give them 3 to 6 months of cyclical estrogen progesterone to prime their uterus and then give them? It is definitely in women with premature ovarian failure or primary ovarian failure, estrogen progesterone therapy for 3 months should be done rather than treating them straight away, because it actually improves the pregnancy rate. How? By increasing the vascularization and subendometrial blood flow. And I've often seen the size of the uterus also increases. Uterus is such an organ that if you look after the uterus well, irrespective of the age, you can get good implantation. We know ovaries change with age. Uterus doesn't change that much as long as you look after the uterus well with estrogen and progesterone therapy. Coming to ovum donation and embryo donation, we prefer more physiological estradiol level. Most of the studies are saying that. And with the oral route, endometrium is out of date. In good old days, we used to do Noah's criteria, looking at the endometrial dating. With the oral route, the dating is out by 1.6 days. Now, we obviously don't do, it's an invasive procedure to check the endometrium in the cycle we are treating, but in the treatment cycle, in the non-treatment cycle, people have done this research to look at this dating. A meta-analysis has shown with the oral route, early pregnancy loss is much higher due to asynchrony between the embryo and endometrium. So whether you look at the FET cycle, whether you look at the ovum donation cycle, people are repeatedly saying that oral route, it may develop good endometrium, it may give pregnancy, but the miscarriage rate or early pregnancy loss is higher. And another study more or less saying the same thing, that in order to, before we can start the progesterone, oral route will have much higher estradiol level. It will take longer duration. The total dose of estrogen will be higher. Transdermal route can reduce the dose, reduce the duration, and thereby there's less chance of cycle cancellation, less cost of therapy. Therefore, it's emotionally much more acceptable. Now, this study said that transdermal estrogen allows the endometrial thickness of more than 7 millimeter as early as 10 days and with a much lower level of estradiol. So the level is 159, whereas with the oral route is 237. Higher endometrial thickness, 8 millimeter comparison to 7.6 millimeter with the oral route. Both of them are statistically significant. Progesterone could be started much earlier with the transdermal than the oral route, again statistically significant. But having said all these things, clinical pregnancy, miscarriage, and live birth rates were not different. So jury is still out. You do not have to use transdermal, but think about transdermal when you have patients who are having pregnancy and miscarriage, or recurrent pregnancy or recurrent implantation failure. Perhaps transdermal can do the magic. So ladies and gentlemen, I would like to summarize that in my personal experience and according to the papers I have presented to you, the transdermal route of estrogen will produce more stable state of estradiol. It is superior to the oral route for induction of endometrial proliferation and embryo receptivity. It is definitely a reasonable option for those women who fail to achieve adequate response with the oral route. And finally, and most importantly, it's a safer option, much safer option in women with high risk of venous thromboembolism and hyperlipidemia. So we will be doing more cases of frozen embryo transfer and definitely ovum donation and embryo donation. So estrogen gel is an effective method of hormone replacement for these women who would require estrogen. And the progesterone, you can use micronized progesterone, you can use dydrogesterone, whatever you want to do. It is great. I'll be ever so grateful if I could have the feedback from the learned audience and the respected seniors in this webinar. Thank you for your patient hearing. Thank you.